and anybody who's good friends with them, I want you to know that. So Al Kraus from what's now Kaiser Group Health, and Jerry Hamilton, both have having some medical problems. So I don't want to be specific, but certainly if you know them and get in touch with them. So the speaker today, Marat, I don't know how to pronounce your last name correctly, so I won't butcher it, but who's a colleague in UW Rheumatology out at the VA, is going to give us a talk on vasculitis. He actually gave us his talk before, but I told him not to worry because none of us would remember from a year ago, and we certainly would need a refresher, and he added some updates.
So it's interesting for me. I didn't realize that allergy and immunology, it's a subspecialty of internal medicine. People have to go through internal medicine training and then go to allergy and immunology. But what's interesting, you have your own boards that are supported by your society, not by ABIM, right? Is that correct or not? It just was interesting to me.
Is that right?
Or you go through ABIM for board certification? No?
Yeah. Yeah, you have to be boarded. You can either be boarded in internal medicine or pediatrics.
Mm-hmm.
You can train in pediatrics and then be a fellow.
Mm-hmm.
And the training is more or less 50-50 pediatric allergy and internal medicine allergy.
Nice. All right. So I mainly, not mainly, I'm 100% VA based. I go to American Lake VA and Seattle VA. So I have clinics there and here in Seattle. So mainly we'll talk about vasculitis. We'll talk about vasculitis today, and generally how to suspect it. And there will be really no medications, significant amount of medications during this presentation. I have no disclosures to make. And the objectives of this talk are understanding concept of vasculitis, how to really recognize it, just know like different groups of vasculitis, understanding like what purpura is, and what do you do with if you see palpable purpura, which is essentially a very pathognomonic for small vessel vasculitis. You will be just you will know how to work up those cases initially, and we'll talk about certain forms of immune complex mediated vasculitis, which happen to be the most frequent small vessel vasculitis. So I'm trying to think what's important, what could be important in your practice of allergy and immunology, and I think that any vasculitis with rash would be probably most important. And if you see rash, you have to know that this is small to medium-sized vessel vasculitis, and we'll go in detail there. And vasculitis without rash, it's large vessel vasculitis that you generally, don't see. It's mainly internal medicine and rheumatology, but those people rarely end up, I think, if ever, end up in allergy clinic. So immune complex mediated vasculitis, of course, you have to have immune complexes. And you do develop Arthus reaction, which is type 3 hypersensitivity. And essentially, the pathophysiology of that is damage to vascular structures and compromised blood flow to organs. As easy as that, but it's a little bit more to that than this. And you have to kind of divide the vasculitis in two big groups: vasculitis with rash and vasculitis without rash. When you talk about vasculitis with rash, you have to divide that one in two smaller groups. It's Pauci-immune or ANCA vasculitis, and and probably people with Church-Strauss vasculitis, somehow end up in allergy clinic, but that would belong here, and immune complex mediated vasculitis. Otherwise, probably the most frequent vasculitis that people encounter, and the most benign ones, because those are very frequently or limited to skin. And so the immune complex formation and clearance actually is important here for immune complex mediated vasculitis. As you know, immune complexes form in normal individuals, and they are actually efficiently removed by reticular endothelial system. And of course, if there is more antigen, or if it's more significant antibody response, or if immune complexes are not as soluble, and if efficiency of reticular endothelial system is, impaired, and if flow dynamics in blood vessels is somewhat impaired, people can get, symptoms of vasculitis. And that's why disease is always, it's not a discrete entity, it's a spectrum. Some get more, some get less of that, some get really subclinical if this is an allergic reaction and just do not get anything. And in vasculitis, immune complexes, they do escape clearance by reticular endothelial system, and they're deposited in blood vessels, joints, other tissues, and that results in inflammation. So Arthus reaction, classically, it's injection of horse serum into rabbits creates circulating antibodies. This is a classical picture. And then injection of the same antigen in the rabbit's ear attracts antibodies to that area with immune complex formation locally, and complement activation and influx of inflammatory cells and formation of the thrombi, hemorrhagic infarction, and subsequent necrosis. And that's what you actually see in skin vasculitis or in organ vasculitis, like an in-organ damage. And you have to think about that in immune complex vasculitis as a constant Arthus reaction. That's what's being happening there. And so where's inflammation in skin vasculitis? And there are obviously small-sized vessels and medium-sized blood vessels. And when we're talking about small-sized blood vessels, those are less than 50 micrometers in size, and they actually are in papillary dermis. If you remember, the dermis is divided in two, essentially. Papillary dermis, those are outpouchings of derma into the epithelium, and those form papilla. And that's where the small blood vessels are. And that's why you get those elements of rash that you can actually palpate, because what you're essentially palpating you're palpating inflammatory infiltrates in the papillary dermis. And then medium-sized blood vessels are mainly presented in reticular dermis, and those are quite bigger. And small vessel vasculitis can somewhat affect medium-sized blood vessels, but generally those are deeper. Those are in reticular dermis and hypoderma, which is essentially a subcutaneous fat. And so where is the inflammation in vasculitis? And essentially, as you can see, a layer of epidermis that you can actually get with shave biopsy, you would not get anything there because there is no blood vessels there, and there is no inflammation there. And dermis, which is very, very, that could be actually diagnosed with shave biopsy. You should not go deeper than that to diagnose small vessel vasculitis, and you actually have most of the inflammation there because you would be able to reach those areas. And as you can see, all the vasculitides which are presented here, HSP, cutaneous leukocytoclastic vasculitis, ANCA, cryoglobulinemia, and connective tissue disease, rheumatoid vasculitis, those are located here. And clinical picture will be essentially the same. You will see essentially the same elements of rash on the skin. And then subcutaneous fat, which you can reach only with punch biopsy or excisional biopsy. It could show some inflammation too, obviously, but mostly you would be looking at medium-sized vessel vasculitis, which is polyarteritis nodosa, which we'll not touch here today. Rash would be somewhat different there compared to small vessel vasculitides. And it's much more rare than any of the small vessel vasculitides that you could see, but you have to go deeper for those. So I would say if you send for a biopsy of the skin, if you do punch biopsy, you will get everything. You know, if you do shave biopsy, you would get only dermis. So in rash and skin vasculitis is essentially palpable purpura, which is very, very suggestive of a small vessel vasculitis. And it's a localized blood extravasation at the site of inflammation. And it actually takes time to heal, like any bruise, like any extravasation, until those, this hemosiderin is not removed. From there, you will see some elements of rash. And then it is most common finding in cutaneous immune complex vasculitis. And other elements of rash could be there because it's an inflammatory rash, and there could be vesicles, and especially if this is a very acute presentation. There could be pustules, urticaria, ulcerations. Ulcerations as a secondary element of rash, as a result of the progression of the necrosis. You could have macules or ecchymosis as a background for the palpable purpura. So palpable purpura on this particular background. And if this is in the fingers or toes, people can get splinter hemorrhages. And here you can actually see all the elements of rash present. So you can see these are palpable elements of purpura. You can see this is not a very acute presentation. We saw this patient relatively late, but in the course, and he has been started on prednisone at that point. But what you can see here, you can still see here papular rash of palpable purpura. You can see here the hemosiderosis of the skin. And what's interesting, what you see here, this patient liked to put his socks like halfway, and you can see Koebner's phenomenon. Koebner's phenomenon is a known phenomenon for psoriasis, where you irritate skin, where the pressure is more, you can actually have this band, or where people scratch and they get elements of rash along the scratch. So that's what's happening. You can actually see Koebner's phenomenon here, several papules along this indentation line. What's that?
Is there a mouse up there? No?
It doesn't show up.
Huh?
It doesn't show up.
No.
We don't have a mouse. Yeah, I'll just show it here. So like here, Koebner phenomenon. So ulcerations. Here is Koebner's phenomenon.
This one is there.
And you can see the papules along this line. Those are papules which are aligned along the most pressures here. And what you can see here also, you cannot see it here, but what you see is it's mostly dependent regions where the hydrostatic pressure in the blood vessels is the most. And in somebody who is mainly sedentary or walking, you can actually see that in the lower extremities. But you can see that on the backs of the patients who are bedridden. So it's basically where the most pressure is and where the most immune complexes are. So it's symmetric and dependent regions. So look for that. The rash is on one foot, look for another, look for the other one too. And histopathology is, and essentially all small vessel vasculitides. Light microscopy would show disruption of blood vessel wall architecture with inflammatory infiltrates. So essentially, inflammatory infiltrates in blood vessel wall. Leukocytoclastic vasculitis is essentially degranulation of neutrophils with endothelial swelling and proliferation, but essentially degranulation of neutrophils, and pathologists would always be looking for that. And then extravasation of erythrocytes. I mean, do you have to have that? Well, you pretty much know when you see the rash that there is extravasation. You don't need any additional pathology confirmation for that because the rash will speak for itself. But what else is important when you order a biopsy? Direct immunofluorescence. And pathologists sometimes in different institutions they tend to do like just slides without immunofluorescence, but you have to ask for that specifically so they can do that. And usually it's better to do like 2 biopsies, and the second biopsy is specifically for direct immunofluorescence. And those are, fluorescent labeled anti-human IgG, IgM, IgA, and C3. Why is that important? Because, for example, you would not be really able to say that this is immune complex vasculitis, or that this is Henoch-Schonlein Purpura, which is basically IgA-mediated, and unless you do this specifically. Why do you need to do that? Because that defines prognosis. For example, if you get an adult with that type of rash, and you completely don't do this study, you would not know that they have HSP. And for an adult with an HSP, it's not a benign disease in an adult. In children, it is a benign condition because it goes away, it tends to go away, it tends to respond to steroids and really go away. But in adults, that means chronic kidney damage. And that's a completely different prognosis. You have to treat that, you have to start treating earlier, and you may have some chances to abort this disease, although the chances are not that high. But I saw actually people who got significantly better with HSP being adults and did really well. And the earlier you start treating them, the better, the less damage to the kidneys they have. So that's how this is important. This is important for diagnosis and for prognosis. So differential diagnosis of immune complex mediated small vessel vasculitis. And so as we all remember, small vessel vasculitis are Pauci-immune vasculitides, like ANCA vasculitides, and immune complex mediated vasculitides. And so differential for immune complex is you always have to consider immune complex vasculitides, small vessel vasculitides, which are not mediated through immune complexes, which is ANCA vasculitis. And you can always, and you should always think about vasculitis mimickers that involve small blood vessels. What would be the most important thing to consider when you see a patient like that? And you probably see people with rashes. When you see on the lower extremities, you see hyperpigmentation rash. Very frequently, patients could be on chronic aspirin, and that happens a lot. Like some people call it hemosiderosis, but essentially what it is, it's pigmented purpura. You can get pigmented purpura because of the allergic reactions, and pigmented purpura is one of the very frequent diseases that people get, although it is a benign disease, and it's not a vasculitis, it's a capillaritis. And that's why you do not get palpable rash here, palpable purpura, but you just have, macules and echinosis, arranged in different ways, but in the same time, it's not a vasculitis, but it's quite frequent and should be on differential. And dermatologists usually diagnose it even without biopsy. They just look at that and only complicated cases or cases which are really hard to treat, they start biopsying that because there is an association with mycosis fungoides there, but it's a rare association anyway. But you have to realize that this is not vasculitis, this is pigmented purpura. And so this is one of the most important mimickers of that. So what's immune complex mediated vasculitis? Once you are in that area, the most common presentation would be hypersensitivity vasculitis. And this could be infection, this could be medication reaction. Like, for example, person starts amlodipine and then they develop this. Most classic presentations are somebody who is on Bactrim or gets sulfasalazine and gets that. You know, and potentially any medication can end up with immune complex mediated vasculitis. Again, HSP, very important, very benign in children and not as benign in adults, mainly because of the kidney disease, chronic kidney disease. Mixed cryoglobulinemia, another, you know, vast topic, but it's immune complex mediated. Type 2 and type 3, which are truly immune complex mediated cryoglobulinemias, are here too. And the presentation on the skin will be essentially the same. Urticarial vasculitis. It's a vasculitis that actually, the first elements of rash are urticarial, which are really itchy. But unlike normal urticaria, they don't go away. And then they progress into the palpable purpura. Then there is an entity which is known Erythema, Elevatum, and Diutinum. Mainly they end up in dermatology clinics, but this is essentially skin vasculitis. And connective tissue disease, rheumatoid vasculitis. For example, people can get vasculitis in normal, absolutely, I would say normal, rheumatologic diseases like lupus, rheumatoid arthritis. Not as frequently now because we treat those, but in the past when there were no disease-modifying agents available, those were quite frequent. And this is essentially immune complex vasculitis and presents essentially the same. Palpable purpura on dependent areas.
It's probably the area that overlaps most with us. The allergists see urticaria all day long. And a big part of the practice. Really, it's in its own category simply because the first presentation is urticaria and not palpable purpura. But the etiologies can be the same. We have to go through the same list. So it's just a definition.
It's just a definition. It's in any vasculitis, actually, the first element of rash, any skin vasculitis, could be urticaria. It just basically says about an acuity of reaction. A lot. So, and there are small vasculitides which are not mediated through immune complexes. It's Pauci-immune vasculitis. Probably here in that area, EGPA would be most interesting to allergists, and probably you get those in your clinics. And for us, the most frequent one is actually microscopic polyangiitis. And then granulomatosis with polyangiitis, GPA. And EGPA, I personally saw only probably 5 cases of EGPA in my practice.
EGPA is a new biologic in our field.
Yep.
As you know.
Yep.
That has approval for that.
Actually, it's very interesting for this IL-5 inhibition for EGPA. As most recently, and there was a study done on a significant amount of patients, 167, and they really were able to show that If you use IL-5 inhibition to glucocorticosteroids, you essentially get much more time in remission than if you don't use it, and the difference is very significant. So nowadays it's really becoming a standard of care if you do treat a GPA. Although I've never used IL-5 inhibition for that. My current patients who are being controlled in that, they're on methotrexate and doing well, so I never had a chance to use that. But definitely, it's something to consider, because this medication mepolizumab that's being used as IL-5 inhibitor, it's being used for EGPA. Although,
I just started one patient on. Anybody else in the room have EGPA on?
Yeah, at the U, we've had quite a few patients. Do you want to summarize that, Drew or Lahari?
Sorry,
We probably have 5 to 10 patients.
I have one patient who's a young patient, 20-year-old with very, very severe EGPA, and she was on rituximab, and she was treated with azathioprine, cyclophosphamide, and she's doing okay now, but she's quite fragile, and right now she's stable after mepolizumab was started.
Dose is higher. The dose is 300.
Yes.
What's that?
The dose is higher than it is for asthma. It's 300.
300.
but again, it's just interesting because you're using it for asthma, and we never use it in our clinic. That would not be an agent of choice in rheumatology. We would go to Rituxan most likely in those patients. If this is not a very, very severe presentation, we can actually go straight to methotrexate with steroids, and that's what I did on 5 patients that I've been following. And they're doing well. But at the same time, something for me to consider later.
The trial actually excluded severe cases, so I mean, it's not like if you have severe EGPA, the trial already excluded those patients, so it's really hard to tell what will happen with those severe patients who should be treated like with cyclophosphamide right away, or who should start with mepolizumab right away. It's hard to tell, but for like mild, like early phases with just allergic rhinitis and asthma, then probably this will be like the best choice because it's just mild.
Well, it's more benign than cyclophosphamide.
Of course.
Well, if you have severe disease, then that will be the difference. If you have like kidney damage, then you want to wait for mepolizumab and get kidney failure. Then I think cyclophosphamide will be a better choice if you have kidney failure. So it depends on how severe your disease is.
We tend to use now rituximab. That would be our agent of choice. If somebody has really kidney involvement, we would actually go first to rituximab and then consider cyclophosphamide if rituximab is not working. Yeah, just because of the side effects of cyclophosphamide overall, and especially in females of childbearing age, we would probably go for rituximab.
How long would you see until you see a response to rituximab?
Usually it's, I would say, if you take an ANCA vasculitis, usually see positive response within like a month or 2, and from that point, if that is working, they should continue to improve, and then we re-challenge them with that probably in 6 months. Usually, we use the doses which we're using for rheumatoid arthritis, 1,000 milligrams, 2 weeks apart, 2 doses total. In the past, we tended to use more of the hematologic dose of 375 per square meter. But now we just tend to use 1,000 times 2 weeks apart, and then just we see if that works.
So in my patient, she received rituximab and she kept having exacerbations and she was not doing well. Maybe within 2 weeks it was decided, I didn't give her rituximab, it was from the rheum team, and we started her on mepolizumab. I don't know which one, worked.
It's hard to say because rituximab usually it takes some time to work, and you cannot really expect much from that. For example, we start with stress dose steroids. I'm sorry, not stress dose, pulse dose steroids, but in the same time, you know, and then we continue with high dose steroids, and at that point, it's really hard to say what's working. But it becomes more clear that rituximab works like a month later or a couple of months later because the doses are going, I mean, they're not going to be pulse dose steroids. And at that point, you would see more effect from rituximab. It's a kind of delayed effect. And most providers would jump to a premature conclusion that the medication is not working. Well, in fact, it just takes some time to work.
One comment, one question.
Mm-hmm.
The word of the day is symmetric. Somebody asked me what it was.
Yep.
And the reason she's not sending it out ahead of time is sending it out ahead of time totally defeated the idea of only people who listen. Anybody could sign on and get credit whether they listen to the talk or not, because everybody got the email. If you go back a slide, I have a question. So we describe these things basically
This one?
on, no, what, the next one.
This one.
Based on presentation. But do we know the underlying mechanism? I mean, why is GPA clinically different than eGPA at a fundamental basis? Do we know the mechanistic difference? You know, we describe these, this is Wegener's, this is Schurich-Strauss, this is associated with atopy, this one isn't. It's a very nice descriptive thing that we've lived with those definitions for years, but if I said why are they the way they are?
So frankly, if to be exact, we don't know exactly why they are the way they are, but there are different antibodies to different entities. For example, anti-MPO antibodies, microscopic polyangiitis, and anti-PR3 antibodies, which actually represent ANCA antibodies for in GPA. What's interesting though, GPA can have both, and MPA can have both antibodies. It's just a tendency, and basically is it's probably a spectrum of one disease, MPA or GPA, but just with different locations and presentation. For example, MPA, it invariably affects kidneys, you know, and GPA affects, it may not affect kidneys with its first hit, and then later on it does affect kidneys too, and that's why you just have to, you know, look at the kidneys all the time when you do lab testing. But for eGPA, it's more of a component of eosinophilic involvement somehow, but otherwise you're really not more on that than anything. And that's basically reflected in treatment too, because we're treating them the same.
You might think in eGPA there'd be anti-eosinophil peroxidase antibodies. Have you ever looked at that? It's a different peroxidase than MPO.
That I don't know, actually. That I don't know. So, again, miscellaneous small vessel vasculitis. Behçet's, you can get vasculitis too, and the presentation would be almost the same. Malignancy-associated vasculitis, that happens too, and that could be immune complex, or it could be Pauci-immune. Infection, that can present as vasculitis, as immune complex vasculitis. And there is inflammatory bowel disease associated vasculitis, and we see that as well. But again, you have to have a bigger disease to attach this vasculitis to. And there are obviously mimickers of vasculitis. Pigmented purpura, just wanted to, we talked about that. Just make sure that you understand that there is no palpable purpura there, but all the rashes there are macules. They could be papules, but those are not really significantly palpable like you saw in palpable purpura vasculitis. Interesting, scurvy, we do not see that as much as it was before, but in pediatrics, I actually saw a presentation of scurvy case in a patient who was basically eating, in a child who was actually fed with bread and cookies, and there was no vitamin C in the diet. What's interesting though, in scurvy, this is essentially the rash, which is ecchymotic rash, very significant. And you would think about vasculitis in this regard, alongside with other symptoms of, oral lesions and losing teeth. Those would be very bad cases. But elevated inflammatory markers, and that's why most people would think, well, they would check the inflammatory markers, and those would be significantly elevated, and those are elevated in scurvy somehow. And many people would not even think about that, but you can actually check for vitamin C. There is, it's an easy test to perform. It's interesting. In the past, like it was quite a problem. If you read the stories by Jack London, he has and he writes about, Alaskan gold rush, and it was, the scurvy was very, 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 very frequent, and he actually gives clinical presentations there, which are quite interesting to read.
This is why British sailors were called limeys?
Yeah. And
You know that? Nick knew that.
yeah. So lemon juice was used to prevent that. The problem, though, in sailors was it didn't really work well because they were boiling it. If you get lemon juice and drink it, you will have plenty of vitamin C. But for if you decide to boil it, there will be almost no vitamin C. And they were really convinced that it didn't work. Well, in fact, it works. But, yeah, so it's very interesting because it has, it has so many relation to literature, 19th century literature, English and American literature, and it's quite interesting, scurvy. So anti-immune thrombocytopenic purpura, but it's not palpable purpura. Antiphospholipid syndrome, TTP is quite frequent. Livedo, Livedo is not a vasculitis, it's just blood vessels. So what actually happens, the arteries of the skin, they get really narrow, and the veins dilate, and that's why you have this Livedo reticularis picture. It's not a vasculitis, and it could be quite normal in many females. If somebody develops it, and when they never had it, you have to think about different pathologies, but essentially Livedo can happen upon exposure to cold. That's quite frequent phenomenon. It's not a disease, but it could be a presentation of antiphospholipid syndrome. It could be a presentation of medium-sized vessel vasculitis and many other things. But in the same time, most people should understand what Livedo is. It's a constriction of arterial blood vessels in the skin and dilation of veins. So warfarin-induced skin necrosis, DIC, cholesterol emboli, atrial myxoma, but those are not inflammatory phenomenons. Those are phenomenons of really blocked small blood vessels. So
none of those would be palpable?
Well, technically, leprosy would be palpable, but it's not, the palpation would actually reveal nodules. Like if you have tuberculoid lepra, those are not, this is nodular rash. If you have lepromatose lepra, those are inflammatory rashes and discolorations. you know, and you can get occasional like ecchymosis here and there, and that's what mimics vasculitis, but it's not vasculitis. So if you suspect vasculitis with palpable purpura, so you have to go through infections, medications, history of connective tissue disease, history of asthma, cough, shortness of breath. Look into the patient's nose. I was able to diagnose significant amount of patients with GPA by just looking at their nasal septum. You know, somebody who has perforated nasal septum, they never used like cocaine in their life, you know, with palpable purpura, the odds are that they would have granulomatosis with polyangiitis. Look in the ears. Look at the perforated eardrums, you know, constant drainage, chronic sinusitis. Those would be indications that people have GPA. So change in urinary habits, I mean, we say that, but generally people with, you know, glomerulonephritis would not really have significant change right away in their urinary habits. And history of malignancy, that would be important thing to consider too. So look in the eyes, look in the sinuses, look in the mouth, look in the nose, and for the reasons that I already described, and just see if this is really palpable purpura with all those features. And we talked about skin biopsy, light microscopy, and always order as a separate study direct immunofluorescence, because that's important for the diagnosis. You will have your diagnosis with that. And obviously, all normal labs, add ANA to that, ANCAs, MPO and PR3, C3 and C4. In immune complex disease, you will get those low, supposedly, if this is a significant immune complex disease. In cryoglobulinemias, type 2 and type 3, those will be low because those are true immune complex diseases. In cryoglobulinemia type 1, those will be normal just because it's not an immune complex disease. It's a monoclonal cryoglobulin. So check for SPEP, UPEP. Those are a rheumatoid factor. So do fellows know what rheumatoid factor is?
It's an IgG.
So rheumatoid factor is an IgM, and IgM it's a big antibody, right? And why do those exist? Do normal people have rheumatoid factors at normal levels? Yes, they do. And rheumatoid factors it's essentially a vehicle to remove other antibodies out of the blood. And that's why those are big antibodies. When do people overproduce it? They overproduce it with inflammatory disorders, or they can overproduce it with some paraproteinemias, like, for example, Waldenstrom's. You can get elevated rheumatoid factor. So, but most likely the cause is either a transient infection. The odds are that would be transient infection, or rheumatic disease. And those are used to remove other antibodies, to remove immune complexes from the blood. And that's why you can get really high levels, like let's say in rheumatoid arthritis, but you can get, so it's essentially IgM. And check for viral hepatitis serologies, because both hepatitis B and hepatitis C are actually associated with immune complex vasculitis and cryoglobulinemia.
As far as the complements, in Pauci-immune, they would not be low. You're not having immune complex.
That's a very good point. In Pauci-immune vasculitis, complements are generally normal. In cryoglobulinemias and significant immunocomplex, even skin vasculitis, those could be low. but it's essentially how much of them are being consumed by immune complexes.
And does it matter if you're having alternative pathway or classical pathway? You have 4 low, you have classical pathway 3, could be either.
Yep. You can have, 4 is usually the lowest one, and you can have C3 to low. In cryoglobulinemias both are usually low in type 2 and type 3 cryoglobulinemias. And type 2 is not that different from type 3 clinically. They are clinically the same, essentially. The only difference is that type 2 is polyclonal IgGs, monoclonal IgM, and type 3 is everything is polyclonal. So, but clinically it's the same. So, and then hypersensitivity vasculitis. That's the one that's most frequent and that begins to resolve within days of removal of the offending agent. You think about this new medication, just stop it and see what happens. Prognosis is usually good if no internal organ involvement, and the odds are that there are none. But in the same time, if you see that on the skin, you absolutely have to check for urinalysis. And I would just even add urinalysis without microscopy. That's because if they do not have any protein in the urine, and protein would be the first thing to have in anybody with glomerulonephritis, you look for protein. If there is no protein in there, the odds are that there is no blood or dysmorphic red blood cells or casts there. That would be the most sensitive thing to become positive. And at the same time, if you see any proteinuria, then you can actually order urinalysis with microscopy. Most of the providers will order urinalysis with microscopy. I don't. And the reason for that is because most of the labs would not give you good amount or would not give you good description for dysmorphic red blood cells in the urine. So for example, if you get urinalysis and you get, no protein and positive red blood cells, what to do with that? Most of the time, these red blood cells would be from trauma, not from glomerulonephritis. But in that case, you will have to go through a significant workup. So that's why I usually use urinalysis, because proteinuria would be very sensitive there. And if there is really slow resolution, because remember that this disease is generally is a disease of extravasated red blood cells, and those tend to be removed really, really slowly, and then this extravasation by itself can potentiate some inflammation because the immune complexes are in there not being removed. Then you can use glucocorticosteroids for a short period of time.
This is immune complex mediated, right?
Yes. And hypersensitivity vasculitis is essentially
Small
poster presentation of immune complex vasculitis. That's what it is.
And then the presentation, how is it different from microscopic polyangiitis, which is?
If you take the skin,
Yeah.
visually, it's no different. And that's why I'm saying that small vessel vasculitis, they're all the same on the skin. The biopsy in that case would show really immune complexes if you do direct immunofluorescence, and that would show complement. If this is, for example, Henoch-Schonlein Purpura, which is not hypersensitivity vasculitis, but it's an immune complex vasculitis, it will be IgA in there that you will be able to see with the diffuse immunofluorescence. But it will all be leukocytoclastic vasculitis with what is leukocytoclastic vasculitis? It's degranulation of neutrophils that you will be able to see there. So basically, you would need on the biopsy infiltration of the blood vessel wall with inflammatory cells. You may see leukocytoclastic vasculitis or may not, but classically you will see it. And sometimes you will see extravasation of the red blood cells. And it's not a required, what is required is that you actually see the inflammatory cells in the blood vessel wall. That's what
But
vasculitis
your
is.
direct question, how does it differ from microscopic polyangiitis? I think that's a Pauci-immune,
It's a Pauci-immune.
where you don't have an immune complex, you
Yeah.
don't have complement
You,
production.
you don't have it there. But you have all the same, features in microscopy otherwise.
Which blood test do you use for immune complexes, or do you just do it off the biopsies?
You circulating
yeah,
immune complexes?
I would say, I actually, I don't check for immune complexes. I check for complement levels and see if those are C3, C4. If those are low, I would be thinking more about immune complex process. But I don't check for immune complexes. I never ordered like immune complex test on, and then biopsies, of
Yeah, we used
course.
to have C3D and C1Q, and then the C3D immune complex test went away through Quest, and now we only have the C1Q
C1Q
immune
binding.
complex. Yeah.
But you're saying there's no need to do that?
I don't do that. I frankly don't do that.
Let's use a biopsy.
I usually guide myself with biopsies too. And HSP, are we good on time? Yeah, no. Okay, so HSP is IgA deposition disease, and again, direct immunofluorescence is important. May occur after upper respiratory infections. So there is aberrant glycosylation of O-linked glycans in the hinge region of a fraction of IgA1A molecules. It was implicated in the pathophysiology of this. But there is an environmental or inherited risk factors required for this disease to happen. So that basically means we don't know what it is. And affected organs involve skin, GI, joints, and kidneys. So you can get very nice symmetric arthritis with that. Small joint arthritis, like rheumatoid arthritis, and in children self-limited, but in adults it's a significant prognosis which could be hard to manage. And you have to do direct immunofluorescence. And cryoglobulins, we talked about that, we'll just quickly go through that. There is no really immune complexes in type 1. Complement levels are normal. And there is clonality, that's why you do SPEP, UPEP on those people, and you can actually get Waldenstrom's macroglobulinemia. In that case, rheumatoid factor tends to be positive. Multiple myeloma, and there is no vasculitis there. But what you have is you have hyperviscosity phenomenon instead. And I saw significant presentations of type 1 with really, blue and necrotic toes and fingers with that, but there is no vasculitis there. It's pure hyperviscosity. And type 2 and type 3, they're almost the same. They're the same clinically. I'm sorry. And you can get, and you know what to check for. Hep C, thinking about infections, and it's all mostly autoimmune in its nature. And yes, it is a vasculitis. It's a true vasculitis. So on light microscopy, you can get leukocytoclastic vasculitis here, and you would get IgG and IgM deposition in direct immunofluoroscopy and with complement components and serology. So it's really important to know how to actually collect that, because if this is not a pre-warmed container, it will be pretty much useless. You have to allow it to clot in 37 degrees, and then you will get your cryocrit, and then it will be reported as a % of cryocrit when it is refrigerated. So that's That's the way it's usually collected. And here is the rash and skin vasculitis. This is cryoglobulinemia type 2. I mean, is there any difference compared to that one that I showed you before? Well, there is none. Because, again, you can see here the same elements of rash, ulcerations. This is palpable purpura. Again, this is partially treated patients with glucocorticosteroids. That's why you do not get this erythematous background. But you can see somewhat here and here, but it's pretty much treated. And you can see there is no good Koebner phenomenon. I would say that this is Koebner phenomenon. Probably results from a scratch. And there are some elements of rash like along this line too of indentation. So those things are easy to read when you know them. So urticarial vasculitis, you can get two types, normocomplementemic and hypocomplementemic. And again, it's the same presentation with small vessel vasculitis, but what initially you would get urticarial rash with that, which is really not that easy to go away. And normocomplementemic urticarial vasculitis typically self-limited, and you get a biopsy because the urticarial rash is not going away, and you will get leukocytoclastic vasculitis there, and interface dermatitis, like with DIF positive deposits in dermo-epidermal junction, which what it is, interface dermatitis, because it's on the border of the dermis and epidermis, and you get classical erythrocyte extravasation. But again, for the diagnosis of vasculitis, you do not need to have that. It's nice to have that on the biopsy, but it's not needed. And hypocomplementemic urticarial vasculitis would be a chronic disorder with, it has some overlapping features with lupus, with low complements, autoantibodies, interface dermatitis, and could be different organs involved. Frankly, I've never seen a patient with that. So I've never seen a patient with that. It could be actually present as a part of lupus too, but I've never seen that. And Erythema, Elevatum, and Diutinum, that I saw that as a resident once. It's quite rare. It's limited to skin, papules, nodules. Again, leukocytoclastic vasculitis, but it's really confined to extensor surfaces of the joints. And so with some evolution of lesions from pink lesions to purple lesions, you just have to know the name, I guess. And it's associated with other connective tissue diseases. Although taking care of connective tissue diseases, I've never seen that. I send many people for biopsies, never seen that report. But that would be reported as leukocytoclastic vasculitis, and then you'll have to make a clinical diagnosis of that. So this is empty, but when you see, patient with a connective tissue disease, lupus, rheumatoid arthritis, anything else, Sjogren's syndrome, they develop vasculitis, probably the odds are that this vasculitis is because of their undertreated disease to start with. And ANCA vasculitis, skin biopsy, it's a good thing that we have skin that we can biopsy because it's an easy organ to reach, but it's really hard to differentiate ANCA vasculitis on the basis of skin biopsy alone for the reasons that we discussed before, because you will have the same biopsy, essentially the same biopsy as you would have with immune complex vasculitis, except for there will be no immune complexes on DIF. So take-home points are, don't be overwhelmed with vasculitis, because when you know what to look for on the skin, you will look for it, and you will have your differential there, which is ANCA vasculitis, immune complex mediated vasculitis, and mimickers. Okay, And the most important mimicker is pigmented purpura, and most benign one, you know. And if you see palpable purpura, it basically means it equals small vessel vasculitis, and this narrows your differential significantly. So you have to be able to recognize it, and we'll look at the picture again. And it could be only skin involved, but it could be multiple organs. The most important organ to check for whenever you see this is kidneys. Order urinalysis. Okay, this should be a minimum that you order, but urinalysis should be there. And you know the initial workup and the value of skin biopsy that we talked about. And remember, no elements of rash of vasculitis. It's here. This is one of the best pictures that I could
Please
provide.
stay at the microphone.
Oh, yes.
Yeah, just because I don't think our outside audience.
Oh, there is outside audience too. Oh, geez, I didn't know that.
All right.
Okay, so as you can see palpable elements of rash, which are papules. Okay, you have some ulcerations there, which is a normal progression of big papules, and especially papules which merge together. And you can see erythematous basis of that. I don't see any pustules in here. Some of the lesions, some of the vesicles may become pustules. If this is an acute reaction, there will be vesicles there, and some of them may become infected with and become pustules. But you can see everything, but you have to be looking for one specific thing: palpable purpura. Do you have any questions?
Except for HSP, is the immune globulin class always IgG in the others, or there
Could be IgGs and IgMs.
an idea?
Yeah, it could be IgGs and IgM, and especially when we're talking about cryoglobulinemia. Could be both.
You mentioned urticaria as a manifestation of vasculitis.
Mhm.
Apart from serum sickness type of reactions, have you seen pure urticaria as a manifestation of vasculitis?
Apart from serum sickness, yes, I did. Yes, I did. And I saw that as a presentation of cryoglobulinemic vasculitis. Again, or it could happen in any type of hypersensitivity vasculitis. You know, it can happen.
So I've seen.
But it would not be the most frequent presentation. But you know, you have to realize like that urticaria could be just something, you know, really allergic, or if you start seeing something else after that, that's when you start thinking about, you know, vasculitis.
So we have a few patients who do not respond to antihistamines at all.
Mhm.
Urticarial lesions, extensive, and one patient, at least two patients had like C-shaped lesions. It was almost targetoid, not complete targetoid lesions. And one of them had a very high anti-TPO.
Mhm.
So I didn't know what to make out of all these, but the lesions actually looked like urticarial lesions.
TPO,
Should I-
thyroid peroxidase?
Uh-huh.
Okay, so I would actually go for a biopsy in that case. And I would be just looking what it is in there. You know, like I would be looking for vasculitis, of course, because of the talk is on vasculitis. But could it be something else? Could it be urticaria by other mechanisms? Probably. And how old was the person and what was the gender?
65 plus male.
Mm-hmm. And do they have Hashimoto's, or are they?
No, he was never diagnosed with Hashimoto's
Yeah.
before.
Mm-hmm.
You know, I started, since he's an old guy.
Mm-hmm. I would just do a biopsy.
Biopsy.
Yeah, I would just start with a skin biopsy.
One more
And
quick question. In Behçet's patients, how often do you see just skin manifestations without ocular or genital lesions?
Actually, most of the presentations would be ulcerative skin manifestations. You know, I would always send patient with Behçet to an ophthalmologist because eye manifestations, uveitis, are quite frequent in them, but mostly the diagnosis of Behçet would be actually suspected if you have certain clinical presentations, which are ulcerative lesions, essentially. You know, vasculitis would not be the thing that, you know, would make you think that the patient has Behçet's, but there are other things that make you think that they have Behçet's, other than, you know, vasculitis. So it would not, let's put it this way, the odds are that if somebody has vasculitis, the odds are that they do not have Behçet's, because it's quite rare in this population. In the population like here, where predominantly, you know, people of Northern European descent. But in the right population, like if you're in Turkey, you know, that would be a different consideration. That's quite frequent there.
Has the prevalence been stable of the different vasculitides, or is there any segment that seems to be increasing, any drug-related or other?
I think drug-related would be the most common presentation. And the vast majority of the cases which we see in clinic, which dermatologists see in clinic, are either drug-related or infection-related, transient infection-related, upper respiratory infections related. Those are quite frequent. And those would be much more common than anything else.
And are there any new drug therapeutics that have been associated with vasculitis? I mean, as we keep getting more different agents, novel agents?
Well, for actually hypersensitivity vasculitis, you pretty much do not need anything but time. And if time doesn't work as fast, you actually need steroids. But you don't need anything else. I mean, hypersensitivity vasculitis goes away with time and steroids, if time is not enough. There are really not needed any novel agents for that. Otherwise, for you know, vasculitis which are significant, like ANCA vasculitis, we, you know, initially, what would be the, you know, the natural progression of ANCA vasculitis in somebody who has a significant ANCA vasculitis with end organ damage? That would be death within 1 to 2 years without treatment, invariably. What actually changed the odds in the favor of the patients is actually starting using steroids. But the most important intervention that was ever done is actually introduction of cyclophosphamide that actually reduced mortality significantly and increased survival rates up to 70 to 80% within the next 5 years. And after that, introduction of rituximab, which pretty much has the same, you know, results, and some people even say better with rituximab than cyclophosphamide, but I think it's not the case. I think that just people want to use rituximab more because it tends to have less side effects and sounds less scary. But, you know, the outlook is pretty good. I mean, do we have cases which do not respond to rituximab? Yes, we do. There are many cases like that. In that case, you know, IVIGs could be used, but generally these people do respond to the therapies that we use, cyclophosphamide or rituximab. And the outlook is much better compared to what it was. And again, ANCA vasculitis, it's a spectrum. And, you know, there are some really cases which are confined to certain organs, and they have them for years, and the patients can stay on azathioprine, methotrexate, leflunomide for years and really respond well. So, but again, what is the severity of there? If the severity is significant, you go for like really significant therapies, like cyclophosphamide or rituximab, and you start them with good dose of steroids.
Thank you very much.
Thank you.
My pleasure.
How did your patient do with the C-shaped? Oh, so
I guess I
Yeah,
need
why don't we
to.
keep it?
he was never responsive, I guess, hitting his
Okay, I get it. I don't do fountain drinks myself. I don't drink fountain. Please don't.
Hey, well, how do you,
Is it Dr. Gates or
Gadzhiev.
Thank you very much.
is it all contiguous? Or is there more food? It's all one thing?
There are other urticarial. There are C-shaped.
How big are they? Are they big? Have you seen any reports that that's?
Do you ever know the names of the school?
It's very itchy.
I
I'm wondering, I've started to wonder, maybe it's because you have this lesion has some underlying thing, because the other patient without no, I don't know how to describe it.
No treatment for it.
But they're C-shaped or?
It's like urticarial vasculitis.
I can't say that I anything like that.
So, yeah,
Here,
yeah.
C-shaped urticaria.
resident, review.
I think it's so.
Well, let me know. And then I can get feedback.
I think it's no.
I know.
Are they inserted part of the body?
So you said.
Could be pressure.
Everywhere. Yeah, my arm will have to. I
I
can.
want to see some palpable.
Thank you.
But urticarial vasculitis can be.
My meeting with you?
Yeah,
Yeah.
so we met briefly before, so Gina mentioned that we were.
You sent me a text yesterday.
Yeah, she can call sick or something.
I don't know.
Yeah, that's right, so, yeah, I guess, the question that we kind of talked about that before is, we have a group of medical
But I was
experts,
just, my
kind
background.
of like, Dr. Cooper who spoke before, and Hector Ortega who spoke before, where they have the, they're still, probably 20% at their
So I was just
academic
curious, we
posting,
should talk about
but then they're kind of like
Oh.
permanent,
Didn't we do fun stuff?
GSK
Well, no, I
type
just wanted to
people.
check out some.
Oh.
I have to do, I got in
It's-
trouble,
that's not
frankly.
No,
That's like downtown.
because it's not part of our checkup box probably.
Yeah.
You know, you gotta have your approved
Yeah, you
hospital
mentioned that.
procedures.
So we have
And
to
you
have
get
a
special training.
presentation like this, which has got obviously no,
Pretty well. That you have
no
the-
interest for any one company.
Right.
So we'd have to look at your list of speakers
You don't do me?
and
Oh.
have
It would
to
just
make
refer
a
to
decision who that would be based on my knowledge
So
and
I
my
didn't mean to
colleagues.
say urticarial vasculitis. What's the other
You
thing?
could bring
It looks
someone
like erythema.
who could give a commercial talk,
Urticaria multiforme.
dinner talk prior to, as
Like
we
that.
usually do on a Monday evening, and then give something that's completely
That's okay, I'll look at it.
commercial.
Oh, so the same group will typically go out to the dinner on the Monday evening, or?
Well,
Not even
or
this.
just give a different talk. I mean, usually the Monday evening, the talk is gonna be a GSK,
Yeah,
edited and
It's not that
clearly
so.
right.
identified
You
as a
want-
John CME
Right.
presentation. No, I mean, it wouldn't have to be the same group. In fact, the university faculty usually
Oh,
doesn't
something
take
like
a
that.
meal.
Something like that.
Something like that, but
So
not
it'd
so
be
much.
your responsibility.
But it's not like it's trying to form a circle or a ring and it
Yeah.
didn't make it?
People who don't necessarily attend this.
Yeah,
Yeah,
so
that's why I said
for the
it's
actual
not
talk, so we have a list, we have 10 of these
That's
people,
it's
and
not
4 of them are
vasculitis.
allergists, and the rest 6 are pulmonologists.
And,
And I have kind of
Yeah.
prepared little bullet points on who they are.
No oral
Want to
issues.
give that to me? Or can I get, I just have to look at it. So it's-
Yeah, I don't know if I could look into seeing if I can give it to you. I was wondering if we have a few minutes, I could kind of just tell you bullet points,
You
just
have
maybe
your
if you
names?
know anybody, yeah.
Yeah.
I got names, look at this.
And do they persist?
No,
Here's
they don't
allergists.
leave anymore, so they don't persist.
That's strange. Is it just some aspect of their epidermis?
I have no idea.
That's
Scratching.
They're itchy though.
People personally. Let me show it to Bill Henderson.
You want to see
Temperature changes, everything.
pictures briefly? I don't know if that helps.
Fresh
Well,
out.
let me quickly, it'd be quicker if he sees names.
Yeah, sure.
Yeah.
Right. What a reference from Valley.
Sorry to interrupt.
I was like, no, it's
This
just great.
GSK is approaching me about a speaker for next year.
Oh, why don't we get the lights on?
Okay.
Good call, good call.
You can just leave, yeah.
I was gonna help you load them up.
Okay, just wait a minute, I have to just do this one other thing.
Sure.
You recognize any of these people that would be a good non-biased speaker or?
Yeah. Nancy Ostrom, private practice, Southern California.
I've seen you.
She's director of a clinical research network, so her big things would be anything related to clinical research, private practice considerations, and then also the women, and all these people are very involved in lots of committees and the Quality Eye and the college and all that. And asthma in women, anything related to that, if you wanted a topic. Joseph Spann is this guy. He's been at National Jewish Health a long time. A lot of academic work been done, and he's still there. He's a pediatric allergist, so he's still at UC University of Colorado Children's Hospital. Camp in the care, COPI, there's a lot of academic stuff.
Oh, you're not?
I'm unattending.
Irini, I can bring up this picture here. So she is. Oh, you know her?
Med school is.
Yeah, Anne-Marie.
Residency,
Board.
fellowship.
She's spouse of Larry Schwartz.
Oh, okay. Yeah, so you know her.
Who the contact
And then
is.
another Anne-Marie Ditto, she's in Chicago Northwestern, so she does a lot teaching sort of thing,
I guess I would.
a lot of volunteer work as well.
Well, why don't, can you give us each copy?
Yeah,
and just run through?
I'm not sure if I can
You're
actually,
supposed to give us that.
I can check on that.
Oh, I
This is
see.
just like notes, I have the bios here, and these are my notes, and I kind of just a bullet point. So we can't read through bios. And then another guy, Nestor Morfino, so he's the guy, he's the pulmonologist list. This one might be very relevant because he has been in the industry for, something like 20 years, and he's been involved in developing antibodies for like many different Th2 cytokine mediators. And he worked on, he was a vice president of medical development at AstraZeneca for a while, so he's big in the development of Fasenra.
But what's his current position?
Yeah, and so basically, these two right here are, they're all called U.S. medical experts. These two are 100% GSK. The rest of them, they're all, they maintain academic postings at their institutions.
Yeah.
So Stan is still at UC Children's. Ronnie, Anne-Marie, she's still going to be in Virginia. So I'm
Yeah,
yeah, right. So not. Okay.
Exactly.
And then they could, yeah, so one of the neat things he's done is had eosinophil heterogeneity, like talking about a lot of the regulatory roles that are starting to be elucidated more thoroughly for eosinophils. So he gave a talk, and it was a non-branded talk at the Quality Eye. It doesn't have to be him, somebody else.
A lot of people, yeah.
I have it.
This guy's an Army guy, he's in the Army a long time. He's in the East Coast, so Army, he does, invited by Army, he does stuff. Senior advisor on teaching. So he, I don't know if our talk, but interesting to talk to. Tom Corbridge of Chicago. He's, this one here, really appears to be really interested in teaching, in modern ways of teaching, revolutionary teaching. So that could be interesting, with not the clinical type that we're used to here, you guys are used to, but could still be seen, I don't know. You guys can figure it out. But David Menino, he was at the CDC. Did a lot of epidemiological studies you guys might be familiar with. He's in Kentucky, still at Kentucky, University of Kentucky there. As
Well, just maybe someone like a national Jewish who's asthma biomarkers, camp cure.
So just somebody, and that would be.
Joe Spann, Joseph.
Yeah. You know him or?